Hi everyone, I'm Andy Grock. I'm an ED doc at the West LA VA, and I'm here today to talk about syncope. So you may have seen a patient with syncope in the ER. You may have had a patient admitted to you with syncope from the ER. It is a super common diagnosis, and I had 3 cases of syncope, one that I admitted and 2 that I signed out, that really drove home something that I'd read about, which is that the evaluation of syncope has enormous practice variability among ER attendings in terms of what lab tests get ordered and who gets admitted and who doesn't. So I did a deep dive into the literature syncope. It took a lot of time. I read a lot, and this is sort of the summary of that. So this is my 3-step guide to syncope. And those 3 steps overall are very simple. So step 1, syncope versus a mechanical fall or seizure. Step 2, you're going to have to figure out, is it true syncope, which we'll define later, or symptom syncope. And 3 is, what is their risk for an arrhythmia? And I wish that this were easier, but unfortunately the 9 previous attempts at making clinical decision rules for the evaluation work of syncope have all failed external validation. There is actually a 10th one that we're going to review that has been recently discovered or formulated, however you want to call it, but it has yet to be tested externally. So step 1, when a patient comes to you with loss of consciousness, you have to figure out through your history or physical exam whether or not it is syncope, a mechanical fall, or seizure. In med school, they kind of give you very clear boxes that patients fit into, and it turns out a lot of what they teach you isn't super reliable when it comes to likelihood ratios and sensitivity and specificity. So if we're going to differentiate syncope versus mechanical fall, for me, the patient has to remember falling and potentially give you a reason for falling and not have any sort of prodrome or symptoms before falling. So I was fine, I was walking, I tripped over a rock and I fell. We know that that's a mechanical fall. The problem is if someone hits their head and they get a little retrograde amnesia, they might just say, I was walking and then I woke up on the ground. And we have no idea if it's a mechanical fall or syncope. In that case, we have to work them up for both and make sure they're safe from both perspectives before we send them home. Syncope versus seizure can also be very tricky. Features like urinary or fecal incontinence usually is associated with seizure, but it can happen in both. The other thing that's brought up is this report of shaking. So patients that seize tend to have clonic-tonic reactions. People with syncope can have myoclonic jerks. So one thing that I use just to make sure whenever I have a report that a patient is shaking is to ask the family member or the EMS person what they saw. And if they just do one little jerk, probably more likely syncope. If they do both arm, full body shaking, then that seems like more myoclonic-tonic movements from seizure. The 2 things that seem to come up a lot in the literature to differentiate seizure versus syncope are a post-ictal period and lateral tongue biting. Patients that syncopize may be confused as to why they're on the ground, but when they come to, they know their name, they know where they are, they know what they were doing that day. People with seizures typically have some period where they are groaning, they don't know their name, they're very, very confused. Next, we have lateral tongue biting. So lateral tongue biting is very, very, very consistent with seizure over syncope. And once again, if you just get that old guy with a bruised head and no one knows why he fell over or what his loss of consciousness was or if he was post-ictal, technically you have to work him up for all 3. But yeah, that's step 1. Super easy. Syncope versus mechanical fall versus seizure. So step 2 is to differentiate between true syncope and symptom syncope. And this is mostly your history and physical exam and any blood work that you send. This is supposed to be what that helps figure out. So true syncope is the patient's walking along, minding their own business. They may or may not have a prodrome, and then they fall over and lose consciousness, followed by a return to consciousness without any symptoms. So this is true syncope. Symptom syncope is a little bit different. So that's when you have some other symptom, then you faint, and then the symptom persists. Or you faint, and then you have a symptom. And we all know this from med school, but it's very weird that these get grouped together. So chest pain plus syncope equals, right, a dissection or ACS. Abdominal pain plus syncope equals, right? Usually we consider AAA, or some other like abdominal catastrophe, right? Fever plus syncope equals some sort of septic process. And then if you have, chest pain, cancer, tachycardia, and syncope, then you have a PE. And I think this is where a lot of the PE literature really, really, really struggles, because people can have syncope from an arrhythmia, from a benign cause, or from anything else that can kill you. This is supposed to be a little grave. I know it looks like a sad face. And this includes this whole list and all the textbooks and pages and pages and pages and pages of text and all of modern medicine. So if you're going to think about like just study design, it's going to be very hard for you to make a clinical decision rule that figures out every arrhythmia risk and then every patient here. And that's why I think a lot of the clinical decision rules have failed, because they take people with syncope on ED arrival and not people with true syncope, which is the population that we really care about in the ER. And so that's our job for step 2, to differentiate between true versus symptom syncope. And I should mention that everyone with syncope should get an EKG while in the ED. There's no real indication for blood work on a specific population or on everyone with syncope. It's sort of supposed to be done on a case-by-case basis. I couldn't find any evidence to do labs on anyone specifically for true syncope. I tend to just take age as sort of an independent risk factor, which we'll get to in a minute. And so for my own practice, if you're over 40, 45, 50, somewhere in there, I will get basic blood work on patients with syncope. But that's not evidence-based, and you may see a different practice among other ED attendings. So step 3 is pretty simple and easy conceptually. When you have someone with true syncope, you need to evaluate them for their risk for an arrhythmia. And you're going to have 2 groups. Either they're high or moderate risk, and then they get admitted for syncope workup, or they're low risk, and then they get to be discharged from the ED. But it actually gets slightly more complicated than that, because multiple studies obviously have looked at what the risks for arrhythmia are, and a lot of them actually have conflicting data. So some studies, for example, say that pre-syncope lowers your risk of something dangerous going on, and other studies say that pre-syncope is just as dangerous as syncope. So I went through all the literature and I picked out the things that seem to consistently come up as dangerous in syncope. And so this is my baseline. If you have any of these features, you need to be admitted for syncope, in my opinion. And other features don't necessarily sway me one way or the other. Now, being terrible at mnemonics, I came up with this. It's called fa-he-he. I know that that's terrible. And these are the 6 things in a patient with syncope that will make me admit a patient. So first is a family history of sudden cardiac death at a young age, death at a young age of unknown cause, or MI at a young age, right? If you have a 30-year-old with syncope and he says that all the male relatives in his family died in their 20s or 30s for no reason, they just dropped dead, that's someone that you're going to want to admit. Next is age. I'll put a question mark next to it. You know what? Let me just surround this one with question marks. So a couple of the failed clinical decision rules used an age cutoff of 65. And some ED docs have interpreted this as saying, you know what, anyone over 65 is not low risk and we should admit. It turns out that those clinical decision rules failed. Other studies found different age cutoffs. And I love how ACEP's 2007 clinical policy describes this. They say there's no specific age cutoff for syncope. Age is a continuous variable that reflects the age and therefore health of the heart. The older you are, the higher risk you are for arrhythmia because your heart's older. But there's no specific age cutoff that will make someone medium risk or high risk. So age is a very, very tricky one. Next, we have heart disease, right? If you have specific historical features in your past medical history that would make you more at risk for an arrhythmia, you need to admit. And the one that comes up a lot are CSF, structural heart disease, and a history of MI or ACS, right? It causes scar tissue, and that can mess up the electrical connectivity of the heart. Next, we have exertion. Any syncope during exertion should be admitted. Next, we have hypotension. And this one confused me a little because I always thought that if you vagaled, you got hypotensive. But I think part of the problem with, or part of why hypotension is important is typically by the time EMS gets there or the patient gets to the hospital, if they're a case of true syncope, some time has passed from their event. And theoretically, their blood pressure should now be normal by the time someone arrives to take it. So if their blood pressure is low, systolic less than 90, or if you want to do relative hypotension compared to their baseline, that's someone that you need to admit. And lastly, abnormal EKG, which we will review next. So for EKGs, there are specific things that I look for to make sure a patient is low risk for an arrhythmia, or to look for high-risk features. And I divide those into 4 groups. 1 is non-sinus rhythm, 2 are abnormal intervals, 3 are evidence of ischemia, which are always bad no matter what's going on, and then 4 are specific syndromes that confer a higher risk for syncope patients. So for non-sinus, I mean, this is my list. AV blocks, I don't include first degree. I obviously include both types of second degree and third degree. Any VTAC or VFib, right? This isn't rocket surgery. Those are pretty simple. AFib, A-flutter in a patient with syncope, you might want to think about admitting. And then lastly, the thing that comes up is PVCs and PACs, in that they reflect some sort of underlying conduction problem in the heart. If someone has like 1 PVC, for example, I don't consider that necessarily an automatic high-risk feature. But if you see 3, 4, 5 PVCs or ventricular bigeminy, or you see 3, 4, 5 PACs, that might be someone that you consider keeping in the hospital. So next, for intervals, bundle branch blocks, right? So left bundle branch blocks, right bundle branch blocks. The other thing that comes up is anterior and posterior vesicular blocks. The QTC interval, always important, right? A long QTC interval in a patient who's syncopized is a little bit of an automatic admit. And then lastly, as long as we're talking about these blocks, there's something called a trivesicular block. This can be a little lecture all on its own. But long story short, you have a right bundle branch block, you have a first degree AV block, and then you have a left posterior or anterior vesicular block. And that's not just someone who's high risk for syncope, that's someone who's at high risk for VTAC, VFib, and sudden death. And typically, if a patient has a trivesicular block and syncopizes, they need to get an AICD on that admission. All right, next we have ischemia. So this is pretty straightforward, but any ST changes, right, ST depressions concerning for ischemia or ST elevations that don't meet a STEMI cutoff, a good old-fashioned STEMI, or Q waves, right? Q waves tend to be a reflection of previous MIs, and if someone has Q waves and previous MIs, it makes them higher risk. Lastly, syndromes. So WPW, Wolff-Parkinson-White, short PR and that upsloping delta wave. HOCM, so usually they have LVH and they have dagger Qs. ARVD, arrhythmogenic right ventricular dysplasia, you can see the epsilon wave. And lastly, Brugada, there's 3 types, look them up on Google. The one that comes up a lot is like the shark fin or the saddleback deformity, so something like that. And those are the things on an EKG that I look for, that I worry about, that would make me admit a patient with syncope. And that's step 3. What is their risk of an arrhythmia? Now, there's a new clinical decision rule that has yet to be externally validated. And I'm going to attempt to draw a Canadian flag. I'm not a very good drawer. Also, my handwriting's terrible. But it came from our good old friends in Canada. It's called the Canadian Syncope Risk Score. And there's a long list of features that have different amounts of points. And some are negative points and some are positive points. I find the whole thing like a little bit confusing to memorize, so I recommend you look it up. But they looked at a population, and this is why I love the study, of what I called true syncope, right? So they took adults with syncope who had no diagnosis at the end of their ED stay. And some patients went home, some patients came in, and they followed all of them, and then they figured out which risk factors were truly important. They came out with this list, right? So a history of heart disease, which is on our list too, a predisposition for cardiac syncope, abnormal blood pressure, so systolic less than 90 or greater than 180, so they had hypertension on there too. They had an elevated troponin. And I guess I can just take a moment to kind of talk about this. So for patients with syncope, there's no evidence-based reasoning on who needs a troponin or who doesn't, or if anyone needs a troponin. So we don't have to send troponins on patients that syncopize, as long as in their history you do not think it's ACS. I will say, when they look at studies when troponins are down on patients, if your troponin is elevated, you are at an increased risk of having a problem from your syncopal episode. So this kind of goes back to this previous discussion on labs for people with syncope. I have a non-evidence-based age guide and history guide towards getting a troponin. If someone has a history of any heart problems or has like risk factors like diabetes, high cholesterol, high blood pressure, or if they're a little older, typically 45 to 50, I'll send a troponin. I don't send it considering ACS in someone with a diagnosis of true syncope clinically, but I send it because if it comes back positive, I know that that person is high risk. All right. Next, abnormal QRS. A QRS duration greater than 130, so left bundle, right bundle. A QT greater than 480, and prolonged QTCs on our list too. And then it's kind of the doctor's decision, is do they think it's vasovagal or do they think it's cardiac? And they came up with a nice scoring system for this, and they've made it very clear that if you're -3 to -2, your risk of having a problem in the next 4 weeks, I believe, was 0.4 to 0.7%. And if you're -1 to 0, your risk is 1.2 to 1.9%. And these are the two groups that they considered low risk. If you're greater than 0, then you start getting in the 3, 4, 5% risk of a problem, and then they recommend admission. So like I said, the Canadian Risk Score has yet to be externally validated. I find it very, very useful in patients that I'm a little bit borderline about, or patients that are considering leaving against medical advice. It's a fairly easy tool that I can look at real quick, and then I can say, well, according to the Canadian Risk Score, this person's risk is very low, and I think that they're probably okay, so I'll send them home. Or a patient wants to leave AMA, sir, according to the Canadian Risk Score, your risk of having a problem the next month is 25%, right? And you can sort of put a number on that medical decision-making or shared decision-making. And that's all you need to know about syncope. Step 1, syncope versus mechanical fall or seizure. Step 2, true versus symptom. And step 3, calculate their risk for an arrhythmia. And you can use my handy-dandy mnemonic, fa-he-he. Sorry, it's a terrible mnemonic. Or you can take a look at the Canadian Risk Score. And that's my lecture. Hopefully now you know everything you need to know about syncope. And I guarantee you, other things are going to come up as time moves forward. But for now, that's my evidence-based guide, 3-step guide to managing syncope patients in the ED. Thanks for listening.